Hello everyone, welcome back to my show, NainaMD, Fusion of Science and Beauty, right here in Beverly Hills, bringing you the best of anti-aging and regenerative medicine. And I'd like to introduce my guest. She's been on the show before. Her name is Dr. Leslie Memsic. She's the most awesome breast surgical oncologist that I know of. She's right here in Beverly Hills, top notch, and thank you so much for coming on to my show.
Thank you for having me.
I wanted to bring you back, and you promised you would come back, which you fulfilled your promise. And that is last show we talked about was about how the changes in technology and so forth and treatments of breast cancer. But I want to focus this time on really breast cancer. When women are faced with it, immediately we think disfigurement. So, and you, who knows better than you? These women must be terrified. And I think I want you to just help the audience to give some empowerment about what kind of surgeries you do, because it's phenomenal what some of the things you're doing.
I think you're exactly correct that after a patient hears the news that they have breast cancer, after they get over the thing like, oh my goodness, cancer, that's such a scary word, then the thing is like, how am I going to look? How is this going to change me? You know, I want to be the real me.
And also in terms of even sexually.
Of course, because it's breast cancer. It's different when someone says you have to have your gallbladder removed. Not near the same anxiety, but breast is a part of how we feel about ourselves, how we interact with our mates, and everything.
And our sexual energy, right?
Absolutely.
It's a part
so
of it.
I think the first thing I do is I discuss with patients that they have choices. I mean, the majority of women that present with breast cancer can be treated with a lumpectomy, where you take out the breast cancer, but you leave their breasts. And there are different ways of doing breast surgery, but you should have incisions that are fairly invisible. Make an incision right around the nipple, right around the armpit, underneath the inframammary fold, underneath the breast, so that even though you've taken out the cancer, and the patient will need radiation therapy, that they have their normal breast back.
So in other words, you're paying more attention to where you're placing the incisions. It was not just like, years ago when I was in surgery, it's like we just cut up pretty much. We just wanted to get the tumor out. It didn't really matter, right? The surgeon really didn't pay attention. You're paying attention to exactly where and how approach you can use, right?
It's crucial to pay attention. Number one, you want to make sure you do not cut any oncologic corners. You want to make sure you cure the patient. But there's absolutely no reason why you can't cure the patient.
And think aesthetically, right? Think aesthetically.
Exactly. It just means thinking about it.
Yeah.
So, and say you have some defect, which I try never to have with a lumpectomy, but then there are plastic surgical procedures that can be done afterwards, including fat injections, etc., to fill out the contour of the lump. So that
the breast, in other words, to provide the evenness and
correct, because we presume that you're going to live forever
Yeah.
after you have your breast cancer treatment.
I mean, Auntie, so obviously it's not an arguable fact anymore. We are capable of living to be 120.
Correct.
It's already proven.
Correct.
The science, we've already, it's already been there, done that. Yeah.
So that is never, if you do need a mastectomy, except in rare situations where maybe your tumor is involving your nipple, we can preserve your skin and your nipple. We're not making huge incisions like in the old days, these horrible cuts that even with reconstruction, you still have this big scar. And it makes all the difference saving your nipple. And so we do that, and we can either use implants, or if you have the correct body habitus, obviously if you're really thin, we have to use implants. But we can actually use your own tissue in many cases to reconstruct your breast so that you don't have any foreign bodies, which for some women is very important.
Exactly. So in terms of the reconstruction, what you're saying is we're just getting much better at it, right?
Absolutely.
And there is a difference between, and I hate to use this phrase, again, because I just have to use it because there is something known as butchering, right? I have to use that, and there's something known as just really paying attention to the aesthetic. Again, the detail, the follow through. So that's everything, which is what you do. And there's a difference then in really how you approach even the reconstruction of the breast, how you even approach the surgery. You could go there and remove more tissue than perhaps that you needed to. You could go in and remove the minimum amount and that you needed to, and so provide that the margins are clear and so forth. We understand all that. So really, there's a finesse involved as a surgeon.
Absolutely, and I think that women should know this and demand.
That's what I'm getting at.
That their surgeons treat them appropriately, and if you feel a bad vibe, if you feel this man or woman is going to scar you for life, you need to get a second opinion.
So there's the need, you guys. So listen to this carefully. Is second opinion. It's okay. It's okay to get when this is a huge thing, and when you're not getting the right vibes, get a second opinion.
Absolutely.
Right? Yeah. Now we moved on. Okay, we've minimized that. We've given the breast reconstruction. The woman is starting to feel, okay, I can get the sexual and my sexuality back and so forth. Now we're living longer. Okay. Now let's talk about not just the quantity of life. Let's talk about what you said earlier is the quality of life, okay? Which is so important to us too as anti-aging and regenerative physicians. So now we're getting to the quality of life. What do you feel, from your perspective as a surgeon, are the quality of life issues that are going to be, that you see are going to be issues?
Well, I think that the medical community as a whole did some studies several years ago which suggested that if you had breast cancer, estrogen, which was given in one form only back in the day, was increased your risk for developing a recurrent breast cancer. In addition, there was a study that was done on thousands of women which suggested if you were on hormones, again, it was not that many options for hormones back when the studies were done, that if you took hormones for longer than 10 years, particularly estrogen along with progesterone, you had an increased risk of breast cancer.
Right.
And so for that reason, the medical community in general has basically said no hormones for definitely anybody with a history of breast cancer. And really, in those women who don't have breast cancer, they should think long and hard about taking hormones because of this increased risk. And basically, the study stopped there. And I think that was an error. I think that we don't know all the details. We have learned so much more about genomics. There are all sorts of different types of estrogens now. There are all sorts of other hormones which can be broken down into estrogens. And I think that and there's receptors. Women's receptors are not all equal.
Right.
And I think the bottom line is, as we've gotten more science, we need to do studies to look into an individual's endocrine or hormone makeup and determine what is the best for them so that they have minimal risk of developing any complications, whether it's cancer or otherwise, but have an optimal risk of living a quality life, not only as long as possible, but as fulfilling and wonderful as possible.
Yeah.
And I think we just don't have the studies right now, but we need those. And I think that women should not just take, I'm sorry, no hormones for you as an answer. They need to speak with a consultant who knows about bioidentical hormones, who knows about the different genomic tests to find out a woman's specific need, so that we can fulfill their need. Yeah. Not give them more hormone than they need, nor hormones that they don't need, or ones that could harm them. Yeah. Part of this is an evolving science. We don't have all the answers yet, but I think that we should demand, this is where women come in handy, we should demand that the science be given, that we start these studies so that we don't just have a one-size-fits-all, whether it's give hormones or say no hormones.
Yeah, yeah. No, I think you're so right, and what part of the things as I go and speak on the subject is that there are some of these studies have been initiated, but they're not in the medical journals, okay? Mm-hmm. You find them in the biochemistry journals, and I draw the nutrigenomic journals. For example, there are two types of generally receptors, estrogen receptors and beta receptors. Huge difference in the affinity and where they lie. Their propensity. So, for example, the beta receptors are more near the periphery of the cell, and the alpha are more near the nucleus, where changes can occur. So that confers just a different, depending on that, if for women, just a different risk sort of profile. Also looking at how they're metabolizing their estrogens. There's good estrogens. In New England Journal of Medicine in 1992 started talking about downline estrogens, of good estrogens and bad. They actually talked about good and bad estrogens. We haven't even looked at that. So you're absolutely right. What we look at in the quality of life that a lot of times is given back to me, either women who've had breast cancer or don't want to get the breast cancer, is that we start to look at those. How are you metabolizing your estrogens? How are your alpha and beta receptors situated, or what's going on with that? What's your xenoestrogen exposure? We're living in a very toxic world. I mean, for goodness sakes, I mean, can't they make any other research? Do they have to make pesticides mimickers of estrogen? Really? I mean, Monsanto can't do anything better than that. So I think there's a lot of xenoestrogen exposure that adds on to that risk factors. And of course, you've got, the stress, the diet. So what we're getting at is, let's say you take two women, right? One her genomic tells her that she's going to get the breast cancer. She's got genes predisposed. The other one has no genes. But through their diet and lifestyle, maybe you can empower the woman who was destined. She may not get it. And the other one, if she didn't do the right diet and lifestyle, she would get it. And that's very empowering. With that note, I kind of want to end the show because it is so empowering to know that changing through nutrigenomics and changing the way you express your genes can change your risk of breast cancer.
I agree. Women have much more power than they think.
Exactly. Isn't that true?
No, that's absolutely true.
So where do they find you? What's your website?
My website is
phone and all that contact
My
info.
website is drmemsic, drmemsic.com. My office is in Beverly Hills, 436 Bedford.
I know, you're right next door to me.
And my phone number is 310-337-9668. Thank you so much.
No, thank you for being on the show. I mean, and this isn't it. I'm definitely having you come back because you know what? In about 6 months, something else would have changed, right?
That's
in
absolutely.
terms of treatment. That's what I'm saying. We've got to keep ahead.
That's right.
Thank you, everyone. I'm going to see you next week on NainaMD, Fusion of Science and Beauty. And if you need any further information, hit me up at NainaMD.com, NainaMD.com. See you next week.